So it is 3 o'clock here in Berlin, and dear participants, on behalf of the company SphingoTec, we would like to warmly welcome you to the first webinar in the series of the three webinars, on the use of novel biomarkers in the emergency department. This webinar will be recorded and later available online. During the webinar, you can type your questions in the text field. It would be great if you can also type your name and the country of origin, because we expect a lot of participants today from a very broad geography. And for our presenter, it will be interesting to see from what countries, what questions are coming in. So now I would like to introduce you our presenter, Professor Salvatore Di Somma. Professor is an expert in emergency medicine and biomarkers intended for use in the emergency department. He is a professor of medicine, the chairman of Postgraduate School of Emergency Medicine, and a director of educational programs at the University of La Sapienza in Rome, Italy. Professor Di Somma is the author of more than 300 papers in the field of acute cardiac care, cardiology, and emergency medicine. Professor is the vice president of the Great Network Association, a worldwide academic research organization aimed to develop research in the field of acute diseases. And Salvatore Di Somma is considered a worldwide expert in utility of biomarkers and new technology innovations in acute diseases. Today, Professor Di Somma will talk about the challenges of recognizing high-risk patients with sepsis in the emergency department and about the utility of novel biomarker Bioactive Adrenomedullin to overcome the challenges. With that, I would like to give the word over to Professor Di Somma.
Thank you very much, Alexander, for the nice introduction. So it's really a privilege for me to be here today to address in the next 30 minutes the importance of managing sepsis in the emergency room. These are my disclosures, and I would like also to address this important question of the worldwide burden of sepsis. We think that there are more than 30 million people suffering from sepsis worldwide. And as you can see from these slides, this disease is much important than other also very important cardiovascular disease and cancer. So we are really talking today on a worldwide critical issue. Why is a critical issue? Because when the patients with the sepsis go in septic shock, the mortality is around 35%. And as a matter of fact, this mortality can even increase of 8% with every delayed hour of treatment. So this is the reason why today we are addressing the importance of fighting with this disease in the emergency room and see how can we improve the management of this really severe illness. Now, when we have the cascade of a patient coming in the hospital, in the emergency room with an infection that is going to deteriorate in sepsis and then in septic shock, and that even the survivors, as you can see from these slides, have some consequence, such as cognitive dysfunction, physical disability, psychological effect. But if you can see the right side of the column, why is the emergency room so important in management of this disease is because when the patients also come back at home, they can come back because of relapse of a sepsis. So there is a really important issue to solve on the fact that emergency provider awareness and triage is crucial in order to reduce the burden of the disease. Now, from this paper, from our group, is very clear that all emergency department overcrowding is always severe linked with mortality. And you can see on the right side of the slides, comparing other severe diseases such as acute coronary syndrome or acute respiratory distress, sepsis is really linked with high mortality in the emergency room due to the 6 hour waiting for diagnosis and the number of deaths in the emergency room because of delay into diagnosis of sepsis is there and is the most crucial, even contributing to increasing emergency room overcrowding. So we are really talking about today on how important is to correctly approach patients with the sepsis in the emergency room. Now, of course, we have guidelines, and the guidelines are going to be important. And we have, as a matter of fact, recent guidelines surviving sepsis campaign published in 2021, where, as I just addressed, there is really important that we recommend an important approach in each hospital to fighting with the sepsis. In other words, this is really need for organizing a special pathway into the emergency room to avoid the progression of infections to sepsis and septic shock. But I would like to address with you that these guidelines that are mainly described for the use of ICU sometimes are very difficult to apply into the emergency room. For instance, you can see that one of the important possibility for emergency physicians to stratify the severity through some score. And quick SOFA score has been used from the previous guidelines of 2016 recommendation as a stratification of risk. But now the new guidelines are going to say that this quick SOFA score probably is not enough. And as consequence, we also know, like we already addressed at the beginning, that it is crucial to start antibiotic treatment, of course, if shock is present, but also don't delay the antibiotic when sepsis is possible. These two questions are really actually not well able to be addressed in the emergency room, because into the guidelines, they suggest to measuring blood lactate to decide to use or not antibiotic. But this is really bad, because I can tell you that the lactate analysis is not a diagnostic tool for sepsis or probably for septic shock. But we need something before lactate, because when the patient has a value of lactate greater than 2, this means there is possibility that the patients go to die. So we need something more before lactate increase to stratify the risk of the patients to develop septic shock and die. From this paper from our group, just published in Biomedicine few days ago, it is very clear that the standard diagnostic tool for sepsis is the culture positive, right? And of course, we cannot have a culture positive result in the emergency room, because it will take 24 hours or even 48 hours. But I would like to show you that all the scores, like the clinical data coming from SARS or quick SOFA, such as heart rate, median respiratory rate, or even Glasgow Coma Scale, are not linked to predict the presence of circulating bacteria into the blood. And even lactate, you see, just confirming what I just said, is really not a marker of diagnostic sepsis. The only biomarkers that is linked with high possibility to detect the presence of sepsis is procalcitonin. And you see, in fact, that I put in green procalcitonin as the only one that at the beginning is linked significantly with the presence of a positive culture. But also guidelines are not going to recommend procalcitonin as a diagnostic tool to start or not antibiotic treatment. So there is a really challenging in making a fast and accurate diagnosis in the emergency room, even using procalcitonin, that actually is the best biomarker we can have in our hand. Let me start to describe a case report. It's a true case report. A woman, 73 years old, came in the emergency room midnight. She was already admitted 3 days before and coming because of pain for kidney stones with a fever and was treated with antibiotic perols and sent at home. She came back again 3 days later because the fever was still high. But at the end of the day, at the triage evaluation, the patient was not so bad, you see. If you calculate the SOFA score, like we can see in the next slide, was just 1. So there was not really possibility to make a diagnosis of sepsis. Of course, there was very clear pain on the Giordano kidney maneuver, confirming the importance of possible pyelonephritis. So I think that we can just think from this clinical approach. It is always the most important thing to do in the emergency room. We're suspicious of pyelonephritis because of presence of stones and high pain in the right hypochondrium should be already diagnostic. So the question is, what should be next? Of course, these patients in the emergency room has fever, has pyelonephritis. This is already there. But the question is, could we know if these patients has sepsis or not? Definitely, we are going to ask for this subject, for this woman, laboratory testing. And in fact, very soon we'll have the increase in white blood cell count. That does not mean sepsis, just mean infections. You see low potassium, probably linked with the assumption of thiazide diuretics. And you can see that there is an increase in reactive C protein, and the lactate is increased, but is not really severe. So this patient was not in septic shock. And also the diagnosis of pyelonephritis was confirmed by the TC scan showing right kidney dilatation with the presence of stones. And then the woman this time was admitted and started the antibiotic treatment EV. And also urologist was consulted, and he was just telling, just wait and monitoring. Now, the most important big question for this case that I assume many of you see every day in your emergency room is, this is a sepsis? The question is, yes, a sepsis. I don't know how can we say this is a sepsis. No, it is not a sepsis. Or the most important probably answer, I don't know. Because at this moment, the patient has pyelonephritis, she has fever, she starts antibiotic, but there is no confirmation of sepsis. A little bit later, 5 hours later, during the night, making the monitoring like urologists suggested, there was a really sudden increase of fever. Patients feel very badly. She got skin pallor, the big state of confusion, respiratory rate was increased, high high heart rate level, and also hypotension. Definitely, the SOFA score was 3 at this point, and laboratory tests showed the high increase of lactate, already showing the confirmation of septic shock, and the procalcitonin was also confirming that there was infections, sepsis, and septic shock. Now, 5 hours before, when she arrived in the emergency room, she was absolutely fine, and we were even not able to make a diagnosis of sepsis, and even were not able to detect septic shock. Now, this is the big question for a case like this in the emergency room. Of course, this is a septic shock scenario. Could we have been able to detect it earlier at the moment the patients arrive? This is what we try to achieve as soon as possible in the future, to start the deterioration of infection through sepsis and septic shock, that in a case like this arrive without any kind of a possibility from emergency physician to detect earlier. Now, what do we know from a physiopathological point of view? That in sepsis, we have an important acute vascular dysfunction, even from loss of vascular integrity and also systemic vasodilatation. And we know very well that is the reason why this is this vasodilatation is linked with the occurrence of a septic shock and the need for vasopressor and fluid. And we know very well that is the reason that drive patients with the sepsis to the death. So at this point, compared to the other biomarkers that I showed that are not enough to detect the presence of a sepsis or even septic shock, now it's clear that we need to have a biomarkers that are able to detect the presence of vascular function as soon as possible in septic patients. Now we have a bioactive adrenomedullin. Bioadrenomedullin is a substance that is present into the circulatory vessel. It is responsible for vascular integrity, but also through the part that's going outside the vessel, regulating vasodilatation. So these two functions are crucial by bioadrenomedullin to maintain stability of a vessel function. Now, the good news that using this sandwich immunoassay, we are able to measure in vivo biological active bioadrenomedullin that has a possibility to is dynamically changing independent from inflammation and is really mirroring the acute endothelial dysfunction that is occurring in sepsis. So as a matter of fact, now we can really detect the physiopathological deterioration in septic patients and predict septic shock. And this hypothesis has been confirmed already 8 years ago now from our group that published this paper in Critical Care, measuring a bioadrenomedullin at arrival in patients in suspicion of sepsis. We were able to demonstrate that a value of a bioadrenomedullin greater than 70 picogram ml was linked with the severity of sepsis, with the need for vasopressors, and finally, as a reason of septic shock and death. So this was really the first paper opening the confirmation of the utilization of bioadrenomedullin in emergency room to immediately detect the screening for the patients having septic shock. And what was really important when you have a single center study, that the next study, multi-centric, from other cohort in other countries are going to show the same results. And we were very happy when 3-4 years later, these three big trials, Adrenos, Albios, and Frog ICU, were able to confirm perfectly what we showed the 4 years before, that the cutoff of 70 picogram ml in this big cohort of number in patients were confirming the need for vasopressors, the severity, and the diet for shock. So this is very clear data showing that if you measure bioadrenomedullin in the emergency room at the patient's arrival, and you even don't know if there is a sepsis or septic shock, you can immediately detect the patients that are going to die because of the value of bioadrenomedullin greater than 70. There are so robust data from this multi-centric trial that now there is really no doubt that it's time to try to use bioadrenomedullin to early discovering of septic shock. But not only that, so this showed the importance, the data that I showed so far demonstrated the importance to detect the bioadrenomedullin at arrival in the emergency room. But what is important again for our study is that if you are going to change from high level to low, these patients are going to survive. While if you are not going to impact the value of a cutoff and the value of bioadrenomedullin remain high also 4 days later, this means that there is no possibility to reverse the negative outcome. So this includes the concept that you can monitoring bioadrenomedullin to evaluate the treatment efficacy. And this again was confirmed from our preliminary study, both from this multicentric study, Adrenos 1 and Albios study. What is important, that means that you can monitoring bioadrenomedullin to see if the treatment, that is fluid or vasopressor, are really able to reverse the severity. I mean, if a patient come in with a value of 75, and thanks to fluid or vasopressor, you are going to go on the value of 35, this patient could be safely discharged. Now, this is really what is important that we know from the use of a bio-adrenomedullin in the emergency room. As you see here, value of bio-adrenomedullin can raise greater than 70 2 days before shock arrival. And also you can monitor bio-adrenomedullin to save the life or not. I think this is really something that is going to change our practice. We are also now looking other disease, and this is my group recent study demonstrated also in pneumonia, both from COVID or non-COVID, bio-adrenomedullin level can detect immediately 10 days and 30 days mortality in patients with pneumonia. So again, this demonstrates that these biomarkers or the endothelial dysfunction can have a lot of important information also in other disease. And you can see how the level of bio-adrenomedullin is linked with the severity, which is the CARB 65, that is a score of severity in pneumonia. And when you check in these patients with pneumonia, which is the best predictor of the risk, you see that the bio-adrenomedullin is much better than CARB 65 and SOFA score, and also better than kidney dysfunction biomarkers, PenKid, that we can discuss in next seminar. Now, just going to be in concrete, which are now the possibility to be fast and accurate in the emergency room? We are going to use as much as possible ultrasound point of care in the emergency room, and also point of care biomarkers, because emergency physicians, they need to apply to clinical judgment laboratory biomarker testing plus ultrasound evaluations. And in fact, what is really good news that now we can have a bio-adrenomedullin level that I showed you in previous slide, how important it is to detect immediately the occurrence of a septic shock, and it's also to start 2 days before the patients go to have septic shock, the treatment using whole blood in this disc, in this machine, this IB10, that is able to give you the result in 20 minutes. So using the bio-adrenomedullin in point of care is going to give a big opportunity to emergency physician to take therapeutically decision. And you know that using biomarkers in the emergency room, but in all the setting, is crucial to have therapeutical implication. It is very clear that if you have in 20 minutes is this whole blood point of care bio-adrenomedullin, you can take clinical therapeutical decision. And in fact, in our ongoing experimental in Rome, we are showing that looking at patients with the sepsis in the emergency room, if we have a patients analyzed with bio-adrenomedullin in 20 minutes by point of care IB10, and you see that if the patient coming with the sepsis and this value is below 70, these people are going to have a very good prognosis. While if the value of IB10 coming 20 minutes later after the arrival in patients in the emergency room is greater than 70, these patients are going to die. So this is also our preliminary demonstration that using point of care detect the bio-adrenomedullin, you can screening the risky patients and making different decisions. Now, we saw from the guidelines that measuring lactate is really important. Although it is late, lactate is always important to measure at admission, because it's going to tell you if the patient has a value greater than 2 millimeters per liter, this patient is already septic shock. In this other paper, we showed that if you are going to add bio-adrenomedullin to lactate that is already elevated, you see that the mortality is around 50%. Because lactate and the bio-adrenomedullin are mirroring different physiopathological ongoing mechanisms, because lactate is mirroring ongoing organ dysfunction, while bio-adrenomedullin is targeting endothelial dysfunction. This is also the reason we can go to use together. And this is confirmed from the case that I would like to show you using IB10 in the emergency room. these patients arrived around midnight again, already suffering from high fever, blood pressure a little bit low. At the end of the day, it was coming from some left lower abdomen quadrant pain. You see that procalcitonin was elevated, so it was already a suspicion of sepsis. Lactate was already high, and in fact, it was already a situation of potential septic shock. Already patient clinical was not having septic shock, blood pressure was still normal, but bio-ADM evaluation at the point of care was very high, 120. And so this was very clear that there was a possibility that the patients, although the clinical scenario was not of shock, was having already a shock, as in fact, this patient was immediately treatment as a septic shock, but although there was all done as noradrenaline, the clinical condition were deteriorating, and the fact that bio-adrenomedullin was 120 and lactate was more than 4 detected the occurrence of a septic shock and mortality. So this means that we can have really a target for our therapeutical decision using bio-adrenomedullin. And the good news that we are developing a monoclonal antibody, the name is Adrecizumab, that is able to counteract the vascular dysfunction in sepsis and septic shock. And in this paper that just came out at the NOS2, that was able to measure the efficacy of Adrecizumab in patients with elevated bio-ADM greater than 70 and DPP3 and other biomarkers of mortality below 70, showing that if the patients having DPP3 below 70 and bio-adrenomedullin greater than 70, this was a risky patient, but Adrecizumab, that was the monoclonal antibody counteracting the effect of bio-adrenomedullin, stabilizing the vascular integrity and the vasodilatation, was able to reduce mortality. So the good news that in future, like the study Adrenos2 showed, we can even use in the early phase in the emergency room this monoclonal antibody Adrecizumab when bio-adrenomedullin is greater than 70 to save life. And at the end of the day, waiting for Adrecizumab, we already can do something, because if a bio-adrenomedullin is elevated and we are able to detect this in 20 minutes in the emergency room, we can start vasopressor, increase the dose to counteract the ongoing vascular damage before the patient's going in septic shock. So there is no doubt that now we have a new options that we can really do something, measuring bio-adrenomedullin. We can measure this with the point of care, and we can definitely reduce the mortality of a patient with the sepsis and septic shock. So just to go through the conclusions, we can just summarize that sepsis is a worldwide severe disease with a high mortality rate, especially because if you are not going to make an accurate and proper diagnosis of sepsis in the emergency room, you cannot reduce the occurrence of septic shock. Actually, we have the guidelines, but the guidelines are very good for ICU patients, where you have the patients in the bed, you can monitor it, but are not really enough in the emergency room, where we need something to immediately detect the severity of a patient, that the patients coming in the emergency room with the sepsis, they just come with the suspicion of infections. But as I show you in the two cases, these patients are suddenly to die for septic shock. So what we need, this is really, we need a new biomarker for early detection of a septic shock. And as I try to show you, bio-adrenomedullin is a biomarker of acute vascular dysfunction that has proved to be very efficacy in early detection of septic severity and risk stratification in AD. Because at the end of the day, if you have a patient that seems to be stable, but bio-adrenomedullin is greater than 70, you need to start soon vasopressor demand, vasopressor treatment in order to reduce the occurrence of septic shock. And also, you can monitoring after bio-adrenomedullin 3-4 days later to see what is the effect of these vasopressors. So it seems very, very clear that using also this very simple cutoff of 70 picogram ml is enough adequate to give information. And it seems that even if you have a patient with lactate greater than 2, when you use bio-adrenomedullin, you can not only detect septic shock, but also high mortality. And in the future, we can have this monoclonal antibody, Adrecizumab, that can counteract the effect of bio-adrenomedullin. Of course, I never finish my talk without recommending to use biomarkers in the emergency room really with care, because you not need to treat the number, you need to treat the patient. So you should put the biomarkers value with the clinical judgment. At the end of the day, I would just like to conclude that bio-adrenomedullin is a big evolution that we have now in our hand to try to reduce the burden of septic shock in the emergency room, because I show you that any hour of delay of diagnosis of septic shock in the emergency room is going to be linked with high mortality. And also now it seems that these new biomarkers bio-adrenomedullin that is available on the point of care in 20 minutes, coupled with the clinical judgment, is able to give you therapeutical option. This is the final important message. You have therapeutical options. You can start vasopressor before patients go in septic shock. You can increase the fluid, and you can even in the future have a room for a new drug that is Adrecizumab. I just would like to conclude saying hello from Rome with my group. And we know we are hosting a special issue on biomarkers. So if anybody is interested to send a paper, just look on this announcement of Medicina. Thank you very much again to SphingoTec particularly for the opportunity to address this very crucial and important question of septic management in emergency room. Thank you.
Thank you very much, Professor De Somma, for this very clear presentation, and for especially for integrating real patient cases into the presentation. This was very interesting to see. And we have quite a number of questions already, I can see. Maybe we can go by one. So let us start with a question about the application of the biomarker. What clinical sign triggers you to order a bio-ADM value on admission? How do you decide which patients should be tested?
Okay, this is a very good question. I just finished my presentation telling that the clinical judgment is always important. Of course, it's really difficult to see which are the patients that you should definitely think about to measure bio-adrenomedullin. But I think that all the patients that coming in with fever, and because of some concomitant disease, such as risky diabetes, or such as, I don't know, hypertension, or some kidney damage, are really risk, right, to develop shock. So for sure, in all the risky patients that are simply presenting with the fever or infections, I really recommend to measure bio-adrenomedullin. But also I can tell you that since septic shock is a vasculature damage, bio-adrenomedullin can be even measured out of these risky patients because nobody knows which are the other component. I show in one slide that probably you saw that the paper that we published recently showed that all the clinical judgment were not enough to predict culture positive. So it's very difficult to say which one are the candidate for measuring bio-adrenomedullin. Again, patients presenting in the emergency room with the fever, all the patients that have some risk factor, we can probably use SOFA score, right? But the SOFA score seems not enough. I can have, like I showed in the first case, a SOFA score of just 1, and the patients got septic shock. And in fact, the new guidelines are not recommending SOFA score alone. So you can put together also SIRS criteria. And if the SIRS criteria are more than 2, you can apply. So just to conclude this very important question, all the risky patients, elderly, diabetic, hypertensive, with many risk of initial kidney dysfunction, definitely need to measure bioadrenomedullin. But I will not limit this measurement also for other young patients that can have vascular dysfunction from other disease. So at the end of the day, I would like to close that potentially all the patients come in the emergency room having infections and also procalcitonin probably elevated, confirming the possibility of sepsis, I will definitely measure bioadrenomedullin.
Thank you for this answer. I think that really answered the whole question. Next, can any treatment of the patient on arrival to the ED mask or negativize bio-ADM levels so that the severity of the patient cannot be reflected by the measuring of bio-ADM?
This is a very good question. There are no drugs such as antibiotic or fluid that are what we use regularly that can mask the level of bioadrenomedullin. So this is a very good question. Even if the patient is going to be admitted from the beginning, the emergency physician is going to start antibiotic EV or fluid. This is not affect the value of bioadrenomedullin. And these are the two drugs that are commonly used, right? So there is no doubt that the bioadrenomedullin are not affected by antibiotic and the fluid. So if you are going to give immediately in 1 hour antibiotic and fluid, and your bioadrenomedullin is more than 70 picogram a hand, this patient is going to have septic shock. So I recommend to start as soon as possible vasopressor in these patients. So just to answer properly the question, there are no effect of the commonly used drug for septic patients, such as fluid and antibiotic. Of course, if you start vasopressor in all the patients, this can mask bioadrenomedullin. But I really don't recommend to use vasopressor in patients where you don't think there is a septic shock. Is that clear?
Okay, thank you. Then we have very interesting questions from the UIE, from Dr. Wahed. So the question to the professor is, do expect the bio-ADM levels to rise before that of PCT and lactate in patient case number 1? And can you use bio-ADM to exclude septic shock?
Yeah, the answer is definitely yes. This is a clear case. She was 78 years old, something like that. She was already coming after 3 days, remember? So definitely, at the moment the patients arrived, I was really recommending to use, to measure procalcitonin and the bio-ADM. And this was definitely giving more possibility to, let's say, to reduce the risk of the woman going in septic shock. So the answer is definitely yes. At the moment the patients arrived in that case, I was highly recommended to measure procalcitonin and bioadrenomedullin in order to start appropriate vasopressor and to avoid that 5 hours later she went to have severe septic shock.
Thank you. We also have a number of questions regarding comparison of bio-ADM to possible competitor biomarkers. So the first one of them, Professor, what do you think about the usefulness of the pancreatic stone protein and the presepsin for the management of septic patients? Okay,
let's start to tell you that when you talk about biomarkers, you have to understand which are the physiopathological mechanisms that these biomarkers are mirroring, right? So you can even use 2 or 3 different biomarkers, but what is important that each of them are going to tell you some different physiopathological ongoing mechanisms that you can therapeutically counteract. For instance, for pancreatic biomarkers and sepsis, they are not different to procalcitonin. So they are simply mirroring the presence of bacteria circulating, but are not mirroring vasculature dysfunction. So I recommend using bio-adrenomedullin independently from the other biomarkers that are simply mirroring the possibility that is circulating bacteria in the blood, such procalcitonin and sepsis they do, because they are simply mirroring the potential possibility that is the bacteria circulating in the blood, while bio-adrenomedullin is a biomarker of vasculature dysfunction that is different. So I really recommend if you use a compared biomarker to understand which is the underlying physiopathological ongoing mechanism, and also which is the therapeutical opportunity that you can have when you measure biomarker. Just to come back to clarify this question, there is no comparison between presepsin or bio-adrenomedullin. Presepsin could be a good biomarker to start antibiotic. Bio-adrenomedullin is a good biomarker to start vasopressors, so they can use together. There is no comparison and competition between the two, because at the end of the day, in the future, my dream is all the patients coming with suspicion of sepsis in the emergency room, they can, after the clinical judgment, that is always the most important biomarkers that I suggest visiting the patient, to do procalcitonin or presepsin to check if there is bacteria, and to measure bio-adrenomedullin to check if these patients can have, in the next 12 to 20, 48 hours, septic shock.
This is very clear. Thank you very much. So these biomarkers are showing a different process or pathological process within the sepsis. And that brings us to the next question of comparison bio-ADM to another similar biomarker. Are there studies comparing the performance of bio-ADM and MR-Pro-ADM for prognosis of sepsis?
Yeah. You mean mid-regional pro-ADM?
Yeah, mid-regional.
Okay, of course, I also worked a lot with mid-regional pro-ADM in the past. What is the difference between bio-adrenomedullin and mid-regional pro-ADM? Mid-regional pro-ADM is a pro-hormone, is not the circulating hormone, right? So mid-regional pro-ADM is something that is linked with the prognosis, but is not detectable, is not really mirroring what is circulating. You need to really have an idea what is going on in the vasculature, in the endothelium function and the vasomotion. You need to measure a circulating bioactive. And the bio-adrenomedullin, for instance, is also, as you saw from some slides, able to be, let's say, monitored because it's active, it's ongoing. Mid-regional pro-adrenomedullin is a static biomarker. So there are bio-adrenomedullin precede the active bio-adrenomedullin. So the really innovation, the real revolution that the bio-adrenomedullin represents the circulating true biological active vasoactive biomarkers. Mid-regional is simply a pro-hormone, and also you cannot monitoring it. I hope that it is clear because it's a very important question. There are totally different biomarkers. I think that now having a bio-adrenomedullin, you have the in vivo ongoing vascular function. Mid-regional pro-adrenomedullin is simply a prognostic biomarker and is not a target for therapeutical implication. Bio-adrenomedullin is.
Thank you very much. This is very clear. If I could add on behalf of SphingoTec, indeed, there is a study that compares bio-ADM to mid-regional pro-ADM, and in contrast to bio-ADM, MR-Pro-ADM was not prognostic of the vasopressor demand in those patients, which underlines what Professor Somma just said. So the next very interesting question, and it refers to your experience, Professor Somma, is: do you think it would be optimal to have bio-ADM measurement in both point of care and the central laboratory analyzers?
No, I just don't think that you need the two. From our data, there is very clear validation of using a point of care whole blood on IB10 bio-adrenomedullin totally equal to laboratory data. So there is no room and no need for repeat. So if you have a bio-adrenomedullin at the point of care that is significant for a value of cutoff greater or below 70, you don't need to confirm this in the laboratory, because we have many data that show the validating the value from a point of care to the laboratory. So there is absolutely no difference in the value if you measure bio-adrenomedullin on the IB10 or in the central lab. And so this is also very important, because this is quantitative, it is not semi-quantitative, and so it's absolutely the same value that you are going to expect from laboratory. So please use, like I show you in the data that we are just going to publish also very soon, that we can trust the value of bio-adrenomedullin point of care. We don't need to repeat it in the central lab.
Thank you for such strong support for point of care, Professor De Somma. And the next question also refers to the measurement of bio-ADM. What is the stability of ADM in the blood sample?
Yeah, I mean, this is exactly what is important. It's high stable. At the end of the day, you know, this is the first endothelium dysfunction biomarker that is stable and possible to measure by sandwich assay. You know, we had in the past the endothelium, remember? Endothelium is not stable biomarker, so you cannot measure it. Now, bio-adrenomedullin is quite stable. So from a technical point of view, you are really measuring the stable circulating bio-adrenomedullin with the sandwich assay.
Thank you. Professor, do you expect bio-ADM can become a part of any global guideline in the near future?
Absolutely. This is what I will do tomorrow, based on my experience. But of course, there is any kind of a new experience, because in the life of the biomarkers, right, it takes always a little bit of time for people to start to use, to be convinced of clinical daily practice. But definitely, you know, let me tell you a story. My experience with the BNP started in 2007. Then we wait for 14 years that the BNP now is evidence 1A in acute heart failure. So it takes some time, but to my experience, having so big data coming from a different multi-centric study with the same cutoff, I think really that in the future, having also therapeutic implication, bio-adrenomedullin will be definitely included in the guidelines. From my side, I hope tomorrow, but probably having more experience worldwide would help in this effort.
Thank you. And we are very happy about so many interesting questions. So the next question is, can chronic vasculopathies, e.g. arteriopathy, increase bio-ADM levels?
This is a very good question that open me another possibility. You know, the vessels need a little bit of stable bio-adrenomedullin to be able to function properly. The normal value in the normal vasculature vessels of a bio-adrenomedullin is around 15, 17, right? So this means that if you have a good vasculature functions, your bio-adrenomedullin is not 0, should be around 15, 17. And in fact, we have an ongoing study in Alzheimer's disease where bio-adrenomedullin is too low. And there is a chronic vasculature, Alzheimer's vascular damage that you can restore with Adrecizumab. So I don't know exactly about damage on vasculature beds, but I assume that in that case, bio-adrenomedullin should be quite low. And then you can use Adrecizumab to restore the normal value that again is between 15 and 17, below 20. So in a chronic situation such as Alzheimer's, we have data showing that bio-adrenomedullin in the disease, chronic disease, is a little bit low. And you want to restore bio-adrenomedullin circulation. Probably this is also, I don't have personal experience, is also true in chronic vasculature damage. But in any case, I just would like to remark that in acute setting of a septic shock, and also we have data coming from our preliminary study in acute heart failure that is also linked with congestion when it's very high. So let's say that there are different level of bio-adrenomedullin mirroring different disease. If in patients with sepsis, you have a bio-adrenomedullin greater than 70, this patient is going to have septic shock in maximum 1-2 days. If the patient has bio-adrenomedullin greater than 35 or 40 in acute heart failure, this patient is a lot of congestion. If the patient has a value below 15, this patient has a chronic disease such as vascular damage or Alzheimer. Of course, this chronic part need more study, but we are going and working on that.
Thank you, Professor. And I think you actually partially answered the question I wanted to ask you next. What are causes of ADM levels increased different than in sepsis? But I think you have already listed that.
Yeah, I mean, in acute heart failure, we have a study demonstrating that's very important because also there is room for Adrecizumab. And we have already a study finished in acute heart failure demonstrated it's quite safe to restore endothelial function.
Thank you. And the next interesting question is, could bio-ADM be an interesting biomarker to be included in the code ICTUS?
You mean in stroke?
Code ICTUS. Could it be, Ines? Yes, stroke.
Oh, this is a very good question. To be honest, it's difficult to say because the physiopathological mechanism of stroke is obstructive, right? We are talking about ischemic stroke, I assume, from the question. So this is an obstruction of the vessels. And then I don't think that the bio-adrenomedullin should be, on my knowledge, enough to show something efficacy, because we are talking about a clot that is something different from vasomotion and dysfunction. I don't know if it's clear. About ischemic stroke, that was the question. Alessandra?
Maybe I think Ines is typing. Was the question answered by Professor Di Somma? Yes, that was the question. Thank you.
Yeah. So again, I think that to be honest, I don't see the big value because we are talking about a clot, right? That is closing the vessel. It's not a vasomotion.
And another question, very interesting and not related to sepsis. Are there any studies in oncology with bio-ADM?
Oh, this is another very interesting, let's say, field. You know, at the end of the day, vasculature and endothelial function is included in all our part of the body, right? So we need some experimental model because we arrived to this evidence in septic starting with the animal models. At that time it was pigs in Germany showing this effect. But actually we have not studied any oncology patients to evaluate. I know that in oncology other biomarkers such as vascular VEGF are included because are mirroring the microcapillary and microcirculation increase, but there are more linked to the tumor, right? So in this case, probably if you are going to think that the cancer should be also supplied by more fluid or more blood because of bio-adrenomedullin is an hypothesis, but really this need before to be tested in animal model.
That is true. So coming back to the stroke question, do you think bio-ADM may be useful for hemorrhagic stroke?
This is possible. And this is something, again, that we have to test. Should be probably a high increase because it's mirroring the severity of the hemorrhagic stroke that is not only linked with the TC scan. So this is possible, but again, we have to work in a more detailed experimental. There are also good questions, and I am very happy that this is coming to be an opportunity That means people are thinking in the real physiopathological mechanism of bioadrenomedullin, because all these questions are properly related. But for the moment, let's at least focus on the importance of bioadrenomedullin in sepsis and septic shock. That it seems from the question that is there, because people are thinking to speculate, and I like this.
Thank you. Indeed, the questions are very interesting. I see at the moment one more question in the chat is, when do you think the monoclonal drug Adrecizumab will be available?
Okay, the first study, Adrenosutus, is just published. And I think that we have already data on the safety that are absolutely safe drug. And now the efficacy is there. I hope that 1 or maximum 2 years from now, the drug would be available.
Thank you. I also see some questions from the participants, how to contact you or the company about the biomarkers. So we will send information to all the registered participants with a link to this webinar, which will be available online to watch on demand. And we can also share any information about the biomarker and the point of care device for measuring it. So at the moment,
also my email, is on the last slide, please, is available for everyone. Salvatore di Somma at uniroma1.it.
Yeah. So at the moment, I don't see any further questions. Thank you very much for so many interesting questions. Thank you to the participants for their time. And of course, big gratitude to Professor Somma for his excellent presentation and a great Q&A session at the end. It was a pleasure.
Thank you to all of you for participation, and thank you a lot for the questions. Means that this raised a lot of interest. Thank you, everyone, and hope to see you on next webinar on proencephalin.
Thank you. The next webinar will take part in 2 weeks. Please join us also to listen to the next biomarker.
Bye. Bye.
Bye.